vascular disease, which is heart attacks, strokes, peripheral vascular disease. Let's talk about what standard medicine does in this setting. Angiography, where they insert a dye. They, of course, start with a catheter that starts in the groin because that's a nice big blood vessel. And they course that up through the artery up to the, or the vein up to the heart. And then they're going to release a dye. And some people are allergic or have a problem with the dye. Inject it in the heart so they can watch and see what happens. As we did the cardiovascular lecture, you might recall that if we were to take those catheterizations, those x-rays that are done, and distribute them to 3 of the top centers in the nation on reading those angiograms, we would find a 2/3 correlation. 1/3 of them would be read totally differently, enough differently that it would change the recommendation for the procedure. And if those same pictures, x-ray pictures, were sent to the same angiographers 3 months later, there would still be 1 out of 3 difference. So the effect is not as good as we think. They do stress tests, echocardiograms, EKGs. We do a lot of EKGs. I'm not saying that none of these are necessary, but this is their standard approach. Balloon angioplasty risk. They're now using that catheter and inserting a balloon basically past the area of obstruction and blowing up the balloon to expand the blood vessel. 1% death from that procedure, 4 to 5% will have a myocardial infarction at the time of the procedure, and 1 out of 20 of those patients will need an emergency bypass because of the procedure itself. And within 6 months, 30%, almost 1 out of 3 of those are going to restenose and no better off than they were before. Stent placement, they're doing about 100,000 a year. 1.8 billion, is probably dollars. Let's see, after a year, 7% of those with a stent placement have a heart attack or die, 11% return to surgery, and bypass surgery is costing about $80,000 per surgery. And there is an operative mortality, depending on the center, anywhere from about, typically it's 2 or 3%, up to 25%. Arrhythmias after the surgery, atrial fibrillation is one of the major arrhythmias. A heart attack on the table, about a 1 in 20 to 1 in 50 chance of having a heart attack on the table. 5-year survival, 90 to 95% after a bypass surgery. 10-year survival, 85 to 90%. And after a year, 7% have had a stroke, 5% return back to surgery. This says brain damage in 20%. I can assure you that everybody that's had a bypass surgery has had brain damage. If you do very careful physiologic brain psychiatric and neuropsychiatric studies, everybody that's had cardiac bypass has had some kind of brain insult. 54% is seen right after surgery, 42% 5 years later of this brain damage. Medications, we're familiar with these. Statins. Statins are becoming more and more common. Nitroglycerin, beta blockers, heparin. Heparin and Coumadin are used trying to decrease the amount of clotting that takes place. This is what standard medicine does. We are going to focus on making lifestyle adjustments. Smoking, diet, toxin removal, all of these things are causing inflammation at the heart or blood vessel level. De-stressing life, chelation therapy. If we were to take 100 people who had bypass surgery recommended or 100 people who had amputation of a limb recommended because of the lack of blood getting to that limb. If they were to have chelation therapy, 90% of them would no longer need the bypass surgery or the amputation. One of the problems with standard medicine approach is if there's 2 or 3 blood vessels that are blocked in the heart, that means there's probably 50 to 100 blood vessels that are blocked throughout the whole body. And standard medicine will go in and repair those 2 or 3 blood vessels going to the heart and can't really do anything for the rest of the body. Chelation therapy will decrease the inflammation, decrease the clot formation, decrease the plaque formation so that the whole body is helped and not just a few of the identified blood vessels. The major risk of chelation therapy is venipuncture. It's the same risk as having any blood drawn. There might be there might be some bleeding at the site, there might be some pain. That in people with kidney compromise, we do have to be a little bit more careful because the toxins, the metals that are being taken out with chelation therapy are being filtered through the kidney. And if the kidney has a problem, we do have to be careful with that. If we were to do 100 treatments, 30 to 60 treatments being required, the savings, $80,000 for a single bypass surgery. Between $2,000 to $5,000, we can prevent 90% of them. We want to reduce some of the risk factors. Homocysteine, we know that B6, B12, and folic acid will reduce homocysteine levels. Homocysteine is a toxic substance the body makes, and if there's plenty of those 3 vitamins, those B vitamins, then that level will be down below 8 and reduces significantly the toxic effect of that normal substance that the body makes. C-reactive protein, again, is an anti-inflammatory marker. And there are some natural anti-inflammatories. MSM is something we use, a product called Solmet, but boswellia, curcumin, ginger root, all of those have been found to be natural anti-inflammatories and will actually reduce the CRP level, reducing the inflammation to the blood vessel. Fibrinogen is part of the clotting mechanism, and there is an enzyme on the market called nattokinase. It's an extraction from a soy that actually reduces the ability of the fibrinogen to become fibrin to initiate that clotting process, and actually takes the place, from our standpoint, of Coumadin and the heparin that's being used extensively. One of the concerns we have about using Coumadin on a long-term basis, or the warfarin, is that the clotting is so reduced that if a patient were to fall down, hit their head on the ice, falling on the ice or against a table, then a subdural hematoma, bleeding inside the head, would occur. It would not stop, and then the serious consequences of that, including death.